Hello and welcome, everyone. Thank you for joining us again on a Thursday afternoon and using your lunch hour to learn more about a really important topic that we want to discuss today. We really want to get clinicians aware of what's out there that can really affect your patients, especially if you are involved in the emergency rooms, urgent cares, and all the new combatants, I would say, in the war against are opioid overdoses. So we have, it looks like the audio is not working as well. Is that just let us know in chat. Okay, looks like it works for others. So for today's session, we are offering CME, continuing medical education credits through the Illinois Department of Professional Regulation. And we do have questions at the end of the educational session that will have to be answered in order to be able to get CME credit. So on to the more exciting things. None of our presenters today have any disclosures worth mentioning. We really hope to first increase awareness of the statewide standing order for opioid reversal agents. And so we want people to know Narcan and its other similar agents are available and how clinicians can tap into potential resources for this. We also will want to have clinicians understand what happens when you have unusual products on the market and you experience patients who you might not know what's going on with them. So what's the role of the clinician in recall of products like the diamond Shruumz, as well as how does public health play a part in all of that? And finally, after that, we're going to go into something you may have seen or heard about in the press, which is the spike in overdoses in the Chicagoland area from contaminants, products, adulterants like xylazine and methadomadine. All of these are considered, veterinary tranquilizers. And so with that, I'm first going to introduce our first two speakers, who are Dr. Wise and Dr. Cunard. Dr. Wise is an epidemiologist with the Office of Health Promotion and deeply involved with our opiate response, as Dr. Cunard is our preventative medicine medical advisor. After that, we will go to Dr. Martel, who is the public health administrator for the Winnebago County Health Department and her experience with the diamond Shruumz recall. And we're going to end with Dr. Nam, who is our colleague at the Chicago Health Department, as well as an EIS officer through CDC. And with that, I am going to open it up to Dr. Wise and Dr. Cunard. And just one small housekeeping issue: for all your questions, please answer them, put them in the Q&A session. If you cannot find the Q&A box rather than the chat box, it's the three dots right at the bottom right of your screen. So please put it in the Q&A. We also have additional panelists in the form of Dr. Gastala, who is also very much intimately involved with our SUD efforts, as well as Ase Name and Indira Giri from CDC Foundation, who will be helping answer questions in the Q&A section. Thank you.
Right. Good morning, everyone. And well, I guess it's noon. Good afternoon. I'm Dr. Catherine Kennard again, and I'm going to be tag teaming with Dr. Leslie Weiss, our epidemiologist, on talking about the update to the opioid overdose reversal agent, our procedure and standing order that became effective in February of 2024. So just giving you a quick history for those who might not be aware that in September of 2015, the Illinois Pharmacy Practice Act was updated to allow trained personnel to dispense and or administer opioid reversal agents. And initially that was just naloxone, although another agent that we'll talk about briefly today, nalmefene, has been added. So the standing procedure was issued. It outlines how entities may become authorized to obtain, dispense opioid reversal agents for the purpose of reversing opioid overdoses. In May of 2023, last year, nalmefene was approved by the FDA as an opioid reversal agent. And so we've included that in this latest update to this standing order. And then in January of this year, Illinois schools were added because they need to have an emergency procedure in place and medication on site should persons exhibit signs of opioid overdose while they're on school premises. So that's it. 2015 started. We now have a new agent and schools have been added. These are naloxone entities, and I've included links in here. I think you'll get the slides so you can get further information, but what entities are approved to dispense or administer naloxone and nalmefene? That would be, of course, licensed pharmacies and pharmacists. They do have to report any dispensing they do under this program to the Illinois Prescription Monitoring Program. There are also opioid overdose education and naloxone distribution programs, or OEND programs. Dr. Weiss is going to share a little more information about that. And that could be law enforcement, drug treatment programs, local health departments, hospitals, some of you on this call, and so on. They do have to be registered with the IDHS Division of Substance Use Prevention and Recovery Drug Overdose Prevention Program, or DOP. So I've included the link there with a little more information on if you are at an entity that would like to be part of this program, you can follow up through that link. And then schools registered with the Illinois State Board of Education are now required to maintain a supply of opioid antagonists. They do need to submit, any school that uses an opioid antagonist under this program do need to submit a report to ISB within 3 days of use. And I've included the link to that report, which I think all the school nurses will be very familiar with. So again, either naloxone or nalmefene, even though they're still called naloxone entities, we didn't change the name, either of those can be distributed or administered. There is required training. I'm not going to read through all this. The main 3 points I want to mention is that it needs to be quickly administered to reduce the risk of severe injury or death. Have to call 911, and the goal is to restore normal breathing. And so that's to prevent severe opioid withdrawal, because we really want to make sure the person is breathing normally, and that's our goal, not to try to have them fully awake and so on. It's to restore normal breathing. And then, of course, you should be familiar, for those of you who are administering these reversal agents, with whatever product you have in your facility. Signs, these are the typical signs and symptoms of an opioid overdose. I'm sure everyone on this call is pretty familiar, but we'll just look at them real quickly. Slowed, irregular, or no breathing, that's the main one that we're concerned about. Skin or nails turning blue, extreme sleepiness, unresponsive to a sternal rub or when shaken, or pinpoint pupils. And so again, I just have highlighted here in blue, if an individual is suspected of overdosing, an opioid overdose reversal agent must be administered as quickly as possible because the overdose might result in death. And they can progress fairly quickly. So just a word about naloxone. The procedure and the standing order, I have a link here at the end of these slides. There's a lot more detail that goes into each of the different ways of administering these medications and so on. So you can get a lot more detail there. So I'm just giving you the real high, what I really think you need to know information here. So for naloxone, it can be delivered using an auto-injector intranasally or intramuscularly. And 3 main points. It's safe to give to a child of any age or an adult with symptoms of opioid overdose, even if you're not sure they overdosed on opioids. Go ahead and give it. If you think there's a possibility, give it. Monitor for recurrence of symptoms and administer additional doses of naloxone if needed. Depending on what substance the person might have taken, the first dose may not be enough. You may have to administer a second dose, but for sure they may have a recurrence of symptoms, and so they really have to be monitored to make sure whether or not you need to administer additional doses. And there are no absolute contraindications to the use of naloxone in an emergency. So I'll just reiterate that there's no contraindications to the use of naloxone in an emergency, and an opioid overdose is an emergency. Adverse reactions are related to precipitating opioid withdrawal. And for most people, they are going to be mild, and they will also be self-limited to the half-life of naloxone, which is about 2 hours. So nausea, vomiting, rapid heart rate, hypertension, pain, fever, dizziness. Most people can tolerate it without having these, but if you see these kind of symptoms after administering naloxone, it's related to their opioid withdrawal. Sometimes, rarely, but it does happen, some individuals can also display physical discomfort or aggression when an opioid overdose is treated, or they may have temporary amnesia. But the adverse effects beyond opioid withdrawal are rare. On to nalmefene. It's delivered intranasally and is safe to give this medication to adults and pediatric patients ages 12 years and older. Again, need to monitor for recurrence of symptoms, but I do want to mention that nalmefene has a much longer half-life, 11 hours instead of that 2 hours from naloxone. So it's probably unlikely that you're going to have to administer additional doses after the first one is effective, but just keep in mind that it has a very long half-life. So if you give more than what's necessary, that can lead to that opioid withdrawal, and it can take a long time for that to resolve because of the nalmefene's long half-life. No absolute contraindications to the use of naloxone in emergency, and the safety and tolerability of nalmefene is similar to naloxone. But again, as I said, it has a much longer duration of action. So here's the resources, and I will now turn this over to Dr. Weiss.
Good afternoon, everyone. Thank you for having me today. Just a couple of quick slides. I wanted to kind of touch upon the data and the utilization of the naloxone standing order. So IDPH does keep a registry of all the naloxone standing order entities, and I put together a quick map so that we can see that there are at least one entity registered to use the standing order in 90% of the Illinois counties, so a fairly good coverage across the state. And then with many of these counties that do not have an actual entity registered within their county, they are included in the coverage of an overdose education in a naloxone distribution center. And so 100% of Illinois counties do have naloxone services available with that expansion of the OENDs. Right now, there are 1,516 registered participants with the naloxone standing order. The vast majority are the overdose education and naloxone distribution centers. 36% are pharmacies, and we have 2% of those participants are schools. So a fairly good coverage across the state. And I did also pull out the Cook County and the Collier counties there in that smaller map towards the bottom, just to show that a great coverage across Chicago and Cook County, as well as within the Collier counties. I know in the statewide map, it's kind of a little blob, so I wanted to pull it out and show the full coverage of Cook County. So looking at the registry, we have a great coverage. And let's see, next slide, please. The final slide, and what I wanted to talk about is the way to find those entities. How do we find like the OENDs? And the helpline.illinois.org is a one-stop shop for all things treatment related. I do want to mention that this is funded by our sister agency, DHS, and they have this amazing helpline. It is absolutely fantastic one-stop shop for all things that are treatment related for addiction. So if you go to the helpline.illinois.org under the Get Help, that has a drop down where you can go to search for treatment, and then it will pull up this web page. This is just a screenshot showing search for services. And where it says, I am looking for help with, you can select naloxone and naloxone services, and then you can either get a statewide or you can enter in your address or your zip code and select search, and it will pull up a map that will show you all of the entities that where you could find naloxone, and it has naloxone services. So this is a really wonderful resource to have for multiple reasons, to be able to find those services, as well as to be able to refer patients or friends, family to this service. You can get a person on the phone by calling the number above, by texting help to the number there. And also they have a chat availability. So if you wanted to just get online and chat, that's also available. This is also the way that you would be able to access MAR Now, or the Medication Assisted Recovery Now program, which is also funded by DHS, and we have a DHS colleague on the panel who I'm sure would be very happy to answer any questions related to MAR Now. The wonderful thing about MAR Now is it is a 24/7, 365 service where you can call and the person can get a case manager and get an immediate prescription for induction into a medication-assisted recovery for both opioids and alcohol, which is a fairly new addition. So I will end there, but thank you for having me and happy to answer any questions in the Q&A.
Thank you, Dr. Weiss. And again, please ask us any questions that you have. Happy to answer those. Dr. Martel, please tell us everything you know about diamond shrooms. Dr. Martel, you might be muted if you're speaking. Let me see if we can. Dr. Martel, it shows that you're muted. Could you unmute? Okay. All right, we can hear you now.
Okay, great. I apologize for that. So diamond shrooms, and I come back to, this is not your typical communicable disease or environmental health inspection. But just to give a little background information, diamond shrooms was a brand of products that included chocolate bars, cones, gummies. There was recalls issued in June 27th of 2024 for profit premium brands. And again, on June 28th, the FDA did an advisory on recall. Distributed nationwide, these products. And as of the most recent data that was pulled down on September 18th, there were states with cases 33. We had the unfortunate, I guess, distinction of being the first in Illinois. But to date, there's been 169 reports of illnesses with 66 hospitalizations and 2 deaths with potentially associated with these products. Now, the interesting part about this, products is, according to the FDA, when they've tested these shrooms, they have a multitude of active compounds. And I know I have a pharmacist presenting later, so they can help me and make sure I'm saying these all right. But muscimol, which is got GABA, inhibitory neurotransmitter of the CNS, so you get the CNS depression on it. Acetylpsilocin, which has a serotonergic psychedelic drug. Psilocin, serotonergic psychedelic drug. Pregabalin reduces electrical activity in the brain and blocks nerve transmission signals. Desmethoxy, I'm going to say anginin, which has properties of it's a monoamine oxidase inhibitor. So it increases dopamine levels, so it acts as somewhat of an antidepressant. And then you have dihydrocavin and cavin, which is part of the kava plant. And again, it facilitates function of the GABA-A receptors similar to benzodiazepines. So the challenge is, it's not just one active compound that's been found in shrooms and this brand name product, it's the combination, which is making it very challenging and probably explains the multitude of symptoms that individuals may present with. And so this slide is taken from the official CDC health advisory from the HAN, which was released on June 12th. Severe potential illness associated with consuming diamond shrooms, trademark brand of chocolate bars, cones, and gummies. So based on the compounds, it's not surprising that some of the reported symptoms included seizures, agitations, uncontrolled muscle contractions, loss of consciousness, confusion, sleepiness, nausea and vomiting, abnormal heart rates, both tachycardia and bradycardia, hypertension and hypotension, hallucinations, choking, excessive sweating, and of course, the thing most concerning is the respiratory failure. So again, it's really the FDA is very concerned about the combination, because while these drugs may be understood, or the compounds individually, it's the combination that is very challenging. So how did we become aware? We understood from the report that we received from IDPH that the patient, the index case, was admitted to the emergency department on August 10th. From August 10th to August 15th, there was work going on with the Illinois Poison Control Center. And it was then reported to IDPH. By the time we received it as a local health department was August 15th. And so we'll kind of come back to some of the lessons learned. Interestingly enough, and we'll go through a little bit more about this individual patient, the good news is they did not end up staying in the hospital. But part of the health department's response was not only that communicable disease investigation, even though I'm going to be upfront, this was not a communicable disease. It's kind of that emerging, it's not even an emerging pathogen, but emerging issue of concern, which required both review of the emergency department visit record, a case interview, and then syndromic surveillance follow-up. But we also initiated simultaneously an environmental health investigation. First of all, food inspections to identify the presence of the recalled product. Knowing that, remember, we talked about the June recalls, and here it is in August, this case is showing up. Do we still have product being sold? We knew we had product being consumed, but we didn't know where it had been sold or purchased or where it had been obtained from. Removal of recalled product from store shelves, and really educating store managers on the dangers of continuing to offer recalled food product. So again, not your typical communicable disease is kind of the focus on the communicable disease. So a little bit of overview of the case. We had learned from records from the ED that this individual worked the third shift. He lived at home with parents. Daily routine was known to vape nicotine in the morning and before going to bed. Was a marijuana user, typically twice a day, but had never tried edibles before. And kind of another interesting social, was a video gamer, and kind of had some networks to work through. So we were able, through our work, we have a data use agreement to access the electronic health records of the hospital of this particular individual. And we learned a little bit about, just kind of a little timeline here, that EMS transported the case at about 5:23 in the evening. Remember, he works second shift. It had a history of disorders, bipolar disorder, anxiety, depression, marijuana, and vape use. Symptoms reported after ingesting a candy bar at approximately 3:45 in the afternoon was, as reported by the parents, it was nonverbal, looked dazed, he was staring blankly ahead, restless, bouncing around the house, fell to the floor and was unable to get up, became agitated and started screaming. And then they activated the EMS system, and the EMS report indicated that he had seizure-like behavior. Now, the emergency department contacted poison control, which had been part of the advisement through the CDC HAN, and the case was discharged that same day, approximately 7 hours later, against medical advice. They had wanted to admit them to the ICU, but the individual chose to leave, which again was very concerning, but kind of an interesting part of it. So when we became aware of the case, we then attempted, as we would with any case investigation, we make multiple attempts to contact via phone and text message. And of course, how many people respond to the health department calling them or texting them? Very few. So at which point I sent a team out, my disease investigator, to the home after the failed phone or text. And when we followed the protocol for case reporting for the Diamond Shruumz outbreak, which we included Appendix A, but we also wanted some additional information because we had not shown up, Winnebago County had not shown up as a distribution site on the FDA is potentially having any stores that were selling the product. We really wanted to understand the source of this product because we are on the state line with, we are the kind of upper border there with Wisconsin. I know a lot of people know Lake County, but we are also a borderline. And we were wondering, is it possible that the person may have purchased from out of state? So we then went through a little bit more of the case interview, understanding this presentation. So the day of the emergency department visit, he had gone to the vape shop and had not purchased it, but had been given, I'm going to say, a gift with purchase, a free candy bar. He had vape nicotine in the morning, but acknowledged did not smoke any marijuana or take any of the prescribed medications. Ate fast food at around 11:30 a.m. And the candy bar experience, he ate it about 1:30 p.m. He said it tasted earthy and not like birthday cake at all. That was brand. Super crunchy with crystal in the bar, like chewing bath salts. And we know that there's another group that's, concerned about that. The recommended serving size is a half bar to full bar. These are considered microdosing items, but ate the full bar, due to body size. He didn't think it would be a big deal and did not remember anything after 2 p.m. that day. So syndromic surveillance, which is kind of after the case interview, is taking a look at the data from, and Leslie was on there, Dr. Weiss, she was helping us as well. We said, okay, let's take a look and see. Typically, we're not if it's one case, it's maybe just the tip of the iceberg. Are there others that have gone undetected? And so for those of you who are not familiar in the public health space, we use a system called Essence, which I put up there, electronic surveillance system for early notification of community-based epidemics, but it's really a syndromic surveillance system. And again, it's submitted then to the Centers for Disease Control and Prevention's BioSense, and data can be accessed and analyzed by both state and local health department. And it includes client demographics, the location of visit, time and date of visit, chief complaints, diagnosis, and reason for the visit. So we were fortunate, Dr. Weiss had also been working to provide us with some of the criteria, and we'll kind of give you a little, and it's a very crude, just kind of diagram. So I had my team go back and say, just from the beginning of the year, just for kind of from January on, of course, we know that the product was really around June was the recall when it first began, those kind of reports coming in, but you can see this spike. And in August, there were 11 ED visits that matched the criteria, but based on details, the index case of August 10th was identified. So this really becomes one of those tools. So not only the case investigations, but also monitoring that surveillance data for these unusual kinds of scenarios. So some of the lessons learned from just this portion was setting up search code data in consultation with state partners to identify potential cases early in the process. I think it would have been helpful, when we get some of these out, that we would really like to start setting those up much sooner than when the first index case appears. We also benefited from access to the electronic health records by us because it allowed early identification and initiation of the case contact, because there was some initial concerning, anytime someone signs himself out AMA, what was the necessary medical follow-up that would need to occur? Field investigation provided additional information and allowed the health department to offer support to the individual. The interesting part of this was once we got in touch with the case and he engaged the family as well, they were very motivated to provide information to prevent anyone else from having a similar experience. So I think that, appealing to that altruistic nature sometimes with our clients is very beneficial. But we also knew that the environmental health inspection was needed to ensure that product was not available, preventing additional cases. Because remember, that what we learned from this was very valuable was that he'd been given the product free. He hadn't even purchased, so he would not have shown up on records. But I also kind of want to put a case out there to our healthcare providers that are not part of our usual healthcare system. I know we all rely very much on automated systems, whether it's Epic or Cerner, for automatic case reporting. But healthcare providers, we really need you to report any unusual case or cluster of cases that indicate a public health hazard. So I think many providers are very familiar with our usual list of communicable diseases. But this was an unusual case. He was hospitalized or, admitted to an ED after consuming a hallucinogenic candy bar that was available over the counter as a legal substance. So then what did we do next on the environmental? And again, not your typical environmental health inspection. So, while my team is used to going to food establishments and making sure that they are in compliance with the FDA food code, this was not your typical. So we sent them out at the time we received the report before we interviewed the case, even to get them out. So we really targeted what we called vape shops, tobacco, small convenience stores. 35 stores were inspected, 9 locations were identified with the product, and 124 packages of product were removed from store shelves. So despite the FDA notice, it was still being made available to consumers. And again, we were looking mostly at identified stores that sell primarily tobacco products or any of them. And we also looked for stores that advertise Delta-8, Kratom, CBD oils. This, again, people are thinking these are all natural, they're legal, they're safe over the counter, and these were consumables or edibles. So interesting enough, we kind of found that included tobacco, convenience, and liquor stores. And this is kind of an anecdotal, so please don't, we don't have any confidence levels identified here, but stores that displayed advertisements for Delta-8 or 9, Kratom, or CBD were more likely to have product than those were that advertisement. So clearly they are offering this kind of large consumer grouping of consumable, what are considered safe alternatives, in terms of their mindset, in addition to tobacco and vaping products. So one of the challenges we had is what authority did we have on this? Because they don't fall under the food code. Removal options, we worked with to either return to vendor or discard product. We did find that 100% of our establishments voluntarily complied with the recall, and most chose to return the product to the company directly. But we also wanted to provide information regarding the recall and ongoing FDA investigation, because clearly many of these institutions had not received because they might have been a secondary distribution site. And again, none of them want the product liability, but how can we ensure that that information is getting to kind of maybe a secondary distribution chain? So lessons learned, there was no distribution reported, but products were clearly on the shelves. Not all products are being sold. Some are being given away free. We talked about that displaying of the advertisement. And again, stores chose to voluntarily comply, so we did not have to use any of our public health authorities, which again, we had involved and engaged our state's attorneys should that have needed to occur. Because again, it's one of those areas that's new to us. Distributors were not disclosed by the businesses. Many of the individuals that we encountered were clerks. They were not the business or establishment owners, so they weren't sure how the actual facility got and I think that one of the take-homes is uptake on FDA recall information is limited. And we learned that as well with cinnamon and applesauce products, recently with food contamination, but that a lot of this information does not get trickled down to the next. So here's our contact information, but I want to give credit where credit is due. Todd Kisner, he's our Director of Health Protection, who oversaw the disease investigation. Todd Marshall, who got aggressive on the environmental health. So it takes an entire public health department to really respond to these emerging and challenges that we've not seen before. So thank you for your time, and I'm happy to take questions in the chat.
Thank you so much, Dr. Markell. That was really, truly fantastic and edifying for all of us out there. And our last presentation for the day, Dr. Pham, on to you.
All right. Hi, everyone. I'm Amy Nam. I am a Epidemic Intelligence Service or EIS officer with CDC. I'm currently assigned to the Chicago Department of Public Health. Today I'm going to be talking about our investigation of a unique outbreak of drug overdoses in May of 2024, and then some important points to know as clinicians. So on May 11th, 2024, CDPH was alerted by ODMAP, which is the Overdose Detection Mapping Application Program, that there was this increase in emergency medical services or EMS encounters for suspected opioid overdoses in Chicago. So in 2023, the average number of EMS encounters for suspected opioid overdoses per day in the Chicago area was 27, denoted by the red horizontal line. And on May 11th, there was 50 shown in orange. So while there have been a few spikes throughout the year, the one on May 11th has some unique features. The first unique feature of the spike was that there was this clustering of cases on the west side of Chicago, kind of suggesting a common source of the substances used and then potentially a presence of an adulterant. The second unique feature is that CDPH was notified by the Illinois Poison Center, as well as some hospital partners, that there was an unusual toxidrome observed. So while the patients presented with symptoms of opioid overdose, such as pinpoint pupils and respiratory depression, there was also prolonged altered mental status despite naloxone, as well as bradycardia, hypertension, and downward gaze observed. So on May 14th, CDPH released a HAN alert for providers and community members about the increase in opioid overdoses while awaiting confirmatory testing of the drug samples that were obtained. So on May 17th, CDPH and IDPH requested some boots on the ground assistance from CDC and the Epidemic Intelligence Service to investigate this increase of drug overdoses. And then on May 20th, CDPH sent out a second HAN upon confirmation of a substance called medetomidine in the drug supply. If you haven't already signed up for the Chicago HAN, I highly recommend you to do so with the QR code on this slide. So we were able to pretty quickly obtain blood and drug sample results obtained at the hospitals in collaboration with the Chicago Recovery Alliance, or CRA, as well as the DEA Toxicology Testing Program, or DEA Tox, as well as the Center for Forensic Science Research and Education, or CFSRE. So CFSRE has a lab that's able to do both qualitative and quantitative analysis of drug samples. And on May 20th, they also released a public alert about overdoses linked to medetomidine rapidly increasing across the US. And then on June 17th, CDPH and CDC started the investigation, which lasted about 3 weeks. So what exactly is medetomidine? So medetomidine is a racemic mixture of two enantiomers, levomedetomidine and then dexmedetomidine. So levomedetomidine is not typically prepared or used alone, versus dexmedetomidine, which you all have probably heard of, is the active enantiomer, also known as Precedex, which is used in humans for sedation of mechanically ventilated patients. And it's also used in animals with a different brand name. So medetomidine is basically a mixture of both of these, and it's an alpha-2 agonist, so non-opioid, that has dose-dependent sedation. Sedation usually lasts for about 2 to 3 hours, but can be prolonged when taken with opioids. And it's similar to xylazine, which is another veterinary tranquilizer that has been used as an adulterant in recent years, as well as clonidine and tizanidine. And medetomidine is purely only used in animals for surgical anesthesia, and there's no approved uses in humans. So medetomidine is a pretty potent veterinary tranquilizer, typically used for sedation, analgesia, and muscle relaxation. And it can also cause respiratory depression, bradycardia, and then this interesting initial hypertension and then prolonged hypotension. So medetomidine is about 200 times more potent than xylazine. The common street name for xylazine, if you've heard, is called Tranq, and for medetomidine is called Rhino Tranq, probably because of its high potency. So xylazine was detected in the late 2000s and early 2010s, in small proportions in fentanyl overdoses, but it's been detected increasingly in fentanyl powders and pills during the early 2020s, with kind of the greatest prevalence in the Northeast U.S. But now xylazine is pretty much increasing throughout the U.S. and has been found in drugs that are seized in 48 states. And within the last couple years, from 2018 to 2021, drug-related deaths involving xylazine have increased more than tenfold, kind of showing that this is becoming more and more of a big issue. Oop, oop, sorry, went too many slides. So medetomidine began appearing in the U.S. drug supply in late of 2022 and sporadically found in toxicology specimens collected from patients who presented to the EDs in several other states, including Missouri, Colorado, Pennsylvania, and Maryland in 2023. Early 2024, it was found in Canada, in Toronto and Vancouver. And then in late April 2024, Philadelphia saw an outbreak of overdoses. A few weeks later, Pittsburgh saw it, it's in its drug supply, and then a few weeks after that, we saw it in Chicago. So this is the geographical distribution of where medetomidine has been found as an adulterant in the illicit drug supply. So mostly kind of in the east, Midwest, a little bit south, but it's important to note that just because it hasn't been found in a state yet doesn't mean that it's not there, and it just may not have been detected yet due to lack of testing. So you may be wondering, why is this showing up in the illicit drug supply? First it was xylazine in the early 2000s, and now medetomidine, which is much more potent. So its use as an adulterant may, help to increase the profit for illicit drug traffickers because its psychoactive effects allows them to reduce the amount of fentanyl or heroin used in a mixture, especially since veterinary tranquilizers are much lower cost. It may also attract individuals who are looking for a longer high because veterinary tranquilizers are kind of described as having similar effects for users as opioids, but with a much longer lasting effect than fentanyl alone. And then also there's this unexpected trend of illicit drugs shifting towards more potent substances, from opioids to fentanyl to now fentanyl with tranquilizers. So while there's a reversal agent for medetomidine for use in animals, there are no reversal agents for use in humans. And given that it's not an opioid, naloxone does not reverse its effects. So while there are immunoassay test strips available for detecting xylazine in drug samples, there aren't any yet for medetomidine. So blood and drug samples have to be sent out to a toxicology lab for testing. So next, I'm going to be kind of summarizing some of the toxicology and drug testing data that we had in our investigation. So there were 15 blood toxicology samples that were sent for testing, and 12 of them were positive for medetomidine, which are our 12 kind of confirmed cases. So for these 12 confirmed cases, the blood medetomidine levels range pretty widely from 0.7 all the way up to 63.7 nanograms per milliliter. But besides medetomidine, all 12 blood samples also contained fentanyl. So medetomidine was not the only substance in the blood samples, and other substances also included, cocaine metabolite, morphine, xylazine, and bromazepam. So moving on to drug samples. So there were 10 drug samples that were sent for testing, and 5 of them were positive for medetomidine, shown in the red circles here. And again, all 5 drug samples also contained fentanyl. Substances here are listed top to bottom from highest to lowest concentration. So 3 of the drug samples had a very similar composition, with medetomidine being the first ingredient, and then kind of similar concentrations of diphenhydramine, heroin, and then trace amounts of fentanyl. And then the other 2 drug samples had slightly different compositions. All the drug samples were powders in baggies of various colors, ranging from ivory, white gold, to tan with orange. So moving on to characterizing the cluster of cases. To save time, I won't be going over our methods, but basically we reviewed ED visit records from 3 hospitals in the west side of Chicago from May 11th to 17th. And these 3 hospitals were selected because they had the highest number of EMS transports for opioid overdoses during the weekend of the spike. So in total, there were 178 cases of overdoses involving medetomidine mixed with opioids, 12 confirmed, 26 probable, and 140 suspect. And the gray bars here represent the total number of EMS responses by day for suspected opioid overdoses. And as you can see, there was a significant increase on May 11th. So most of the cases were male, about 80%, and most of the cases were Black and non-Hispanic. In the next couple of slides, just note that confirmed cases are red, probable cases are orange, and then suspect cases are blue. And confirmed and probable cases have the highest suspicion for medetomidine toxicity, so I'd mostly focus on the red and orange bars. So the median age of the cases was around 55 to 60 years old, so middle age, and this kind of aligns with what we typically see for opioid overdoses in Chicago. The most common reported drug used was heroin, followed by other opiates. However, this information was missing for a lot of the cases because we extracted information from what was documented in the patient charts, and sometimes this wasn't documented. So these were the most common symptoms upon ED presentation by case classification. So there's kind of a lot that can be extracted from this slide, but there are a few key points that I wanted to highlight here. So the first is that among the confirmed cases, the most common symptoms were altered mental status, bradycardia, hypertension, and pinpoint pupils. So 75% of the confirmed cases were bradycardic, and all of our probable cases were bradycardic because we use bradycardia for our case definition. And the initial EMS and ED heart rates were sometimes as low as in the 40s. So among the 12 confirmed cases, 3 of them received atropine, which is the first-line medication for treatment of bradycardia, kind of showing how severe the bradycardia was. Confirmed cases were also likely to be hypertensive upon presentation, and especially have hypertensive urgency. And this kind of aligns with what we know about medetomidine, which is known to cause initial hypertension and can help distinguish it from typical opioid overdoses. So most of the confirmed and probable cases did not have full reversal of symptoms after naloxone, which again differentiates it from typical opioid overdoses. So all the patients often received several doses of naloxone, both prior to ED arrival as well as during the ED visit. And there was only one confirmed case that had full reversal of symptoms, but this patient also had the lowest concentration of serum medetomidine, which can help explain why. Confirmed cases had a higher percentage of hospital admission compared to probable and suspect. So about 2/3 of confirmed cases were admitted to the hospital, and about 1/3 of the probable cases were admitted. Among the admitted cases, average length of stay was about 1.6 to 3.3 days, higher for confirmed and then probable compared to suspect. Confirmed cases also had higher percentage of respiratory support needed, such as supplemental oxygen, CPAP, or intubation, with more than half of them needing some kind of respiratory support and about a third of probable cases needing respiratory support. Among the 12 confirmed cases, about a quarter of them were intubated with a median length of 1 day of intubation. And then in respect to complications experienced in the hospital, confirmed cases generally experience higher percentage of complications, with the highest one being pneumonia. And then other complications included acute kidney injury, cardiac injury, such as MI or NSTEMI, encephalopathy, and respiratory failure. And then about 75% of confirmed cases received medications for opioid use disorder or MOUD, such as buprenorphine or methadone in the hospital, and about less than a third of the probable cases did. So we received data from the Cook County Medical Examiner, and there were no deaths directly attributable to medetomidine reported during the date range of our investigation. There was one patient death among the suspect cases, but it was not clear if the death was due to a drug overdose, especially medetomidine overdose, because the patient also had multiple severe comorbidities, including a stroke 2 weeks prior. So here are some possible clinical findings and supportive care considerations for overdoses involving tranquilizers such as xylazine and medetomidine. So this is directly from a veterinary tranquilizers best practices for healthcare providers document developed by IDPH and IDHS that will be sent out after this presentation. So we saw most of these clinical findings in our investigation, especially the hypertension, hypertensive urgency, as well as bradycardia. And Dr. Kostala could probably talk more in depth about this if there are any questions about supportive care considerations. But the general principle is that cardiovascular and respiratory support are critical for the management of medetomidine and xylazine toxicity. So there's also an increased risk for developing skin wounds when injecting substances that contain xylazine or medetomidine. So in our investigation, snorting was also the most common route of administration, which can also contribute to damage inside the nose, resulting in blood and tissue discharge from the nostril. But wounds can also occur at skin sites that are not associated with injection and in individuals who don't inject substances as well. And these wounds often begin as small superficial lesions with a white or purple center and dark red fluid discharge. So we don't have time to review wound care in detail, but we will also send out this handout afterward as well. So some public health recommendations for consideration. So first, we recommend to still continue giving naloxone for suspected drug overdoses. And while medetomidine cannot be reversed with naloxone, we found that 100% of the blood and drug samples in our investigation also had fentanyl, which can be reversed with naloxone. And just note that overdose reversals that have tranquilizer involvement may not necessarily present the same as those without tranquilizer involvement, and that after administering naloxone and performing rescue breathing, a person who is experiencing overdose from both opioids and tranquilizer may begin breathing, but they may still remain pretty sedated. Second, continue to provide MOUD for individuals experiencing substance use disorder because linking patients to MOUD has been shown to reduce overdose rates. If you're not already familiar, Illinois has a helpline called MAR Now, I think that Dr. Weiss mentioned earlier, which launched in 2022, which can connect patients directly to providers for opioid use disorder treatment. So for patients, they can receive telephonic prescriptions for buprenorphine, and they can also get help with transportation to treatment. And then for hospital staff, you can receive assistance with in-hospital buprenorphine induction or referral information to support patients' recovery post-discharge. We also recommend clinical partners to report overdose clusters to the Illinois Poison Center, as well as your local health department, and to send biological and drug samples for toxicology testing, which is especially important for unique toxidromes. This outbreak really was detected in collaboration with hospital physicians and the Illinois Poison Center. And without the toxicology data, we likely would not have detected this outbreak in the Chicago area. And information on the DEA Tox program, which provides surveillance on overdoses of novel psychoactive substances, can also be shared post-presentation as well. And then finally, continue to educate patients about the presence of xylazine and medetomidine in the illicit drug supply. So, some patients may knowingly use drugs with tranquilizers, but a lot of them may not realize that these veterinary tranquilizers are in the drugs that they're using. Patients can test their products for at least xylazine using test strips or a drug tracking program. And surveillance drug tracking is available through the Chicago Recovery Alliance, which is not just limited to the Chicago area. So I have the link here if you're interested. And then also, continue to reinforce harm reduction messages, such as never using alone, starting slow and going slow, and then trying to avoid mixing substances. And then last but not least, reinforce that even with these new adulterants in the drug supply, naloxone should still always be carried and used because drugs are never just one substance, and opioid reversal is still crucial to saving lives. And I'd like to acknowledge individuals at all these organizations that made this investigation possible, especially our hospital partners. And thank you to you all for coming to this presentation to learn more.
Thank you, Dr. Nam. And I'm just going to do the last bit of housekeeping to give people the information on CME before we move forward. Just quick thing, we have 2 other sessions coming up. It's starting to be respiratory illness season, and we have our next session in October around preparing for that. And finally, in November, we are going to really talk about sexual and reproductive health, our birth control, our contraception standing orders, and all the different options that we have that you can at least educate your patients on in Illinois about services that they could tap into around that. So the registration links will be included in what we send out. If you need to reach out to any of the medical advisors, we have a smart form. You can use that to reach out to us. Some of these messages, we like even Dr. Nam had mentioned, including wound care for xylazine, we had sent out through a Siren. So if you are not part of a Siren system, sign up, and then you will get some of these health alert messages around diamond shrooms, around all of these that we do send out to as many clinicians that are on our listserv for this. And finally, this is the link. I'm gonna post the link on the chat. In the chat too, for if you answered these questions, you will get CME. You'll be able to get CME. I'll just keep that on for, let me stop. I'll just put the link in the chat and then open it up more broadly for questions. Any questions? Again, the link for the CME is now in the chat. Please, those who want to claim CME, answer your questions and you'll be able to claim CME for this session. If people want to ask questions, you can also show raise your hands. Then we can see who we need to get off mute if needed. Again, thank you all for spending your lunch hour with us.
Like there is one question here at the end.
Yeah. Yes, Dr. Gunnar, go for it.
Well, I don't know. I mean, is there any concern recommendations around exposure for rescue personnel performing rescue breathing, if e.g. if the drug were inhaled and portions remain near nares or drug ingested by mouth outside of barrier devices? I'm not sure about that. I don't know if any of our panelists have any information on that.
I'm assuming you're thinking maybe like fentanyl, like if you have powdered fentanyl somewhere, someone's snorting it, and then you're doing mouth-to-mouth resuscitation. And Dr. Gastala, open it up to you in case you have any additional insights on that, and I can chime in some thoughts too.
I haven't seen any reports of that from the team members who have been exposed. I there's always possibilities, right? But that is not something that we have really seen or had concerns about to date. But it's a good question.
Yeah, and if you're talking about maybe Good Samaritans who are trying to do CPR on someone who they don't have Narcan available, I think if you see any powder or any liquids on someone's sort of mouth, and that you can do mouthless CPR if you know how to. If you don't know how to, the thing is just wipe off whatever it is. It's not as easy as people think for sheer just contact from fentanyl to experience overdoses. I know there's a lot of mixed media information out there on how fentanyl may or may not cause overdoses, accidental overdoses in people who are exposed. But I think that would just be the common thing. If you wipe off anything that you see is a powder or a substance, you should be fine. All right, great. Any other questions? Happy to answer. I know we're down to the last minute. And even the links, the live links, the presentations with live links and some resources will be sent out to the registrants after the fact. So you can claim your CME through that link after the fact too. Thank you. Take care, everyone. Have a good Thursday.